Professor Emily Banks, welcome to Scotland. You have had such an influence on our thinking here as a Professor of Public Health and Epidemiology in Australia, a visiting Professor at Oxford University. And I wonder, can you tell us a bit about the review that you were lead author on that was published this year?
So we were commissioned by the Australian government to conduct an overall public health assessment of electronic cigarettes or vapes. And as part of that, we did 14 different reports that covered multiple aspects that you really needed to consider when you were looking at e-cigarettes. And I would say that the first aspect of that is to have a really strong sense of perspective of where e-cigarettes fit in with smoking overall. So we know that smoking is the number one problem. Conventional cigarettes, 8 million deaths or more a year, huge cause of disease and disability in Scotland, Australia, worldwide. So we need to know that that is our main enemy. But we also need to know that the main effective things that reduce the sort of impact of tobacco are about reducing uptake in youth and increasing cessation. And the things that are really effective for that at a population level are high prices, they're bans on advertising, health warnings, mass media campaigns, smoke-free spaces. And assisted individual quitting is down the list. It's not the biggest driver. It's not really so much a clinical matter, but that population level interventions. And often when people think about smoking or tobacco control, they think of those individual products, but actually those other things are much more important in driving smoking lower. The other thing is we need to have a perspective on our population. So in Australia, around 11% of adults are current daily smokers, and around 89% are not. So the figures are 14% in Scotland and 86% are not. So when we're thinking about interventions to improve health, we have to focus first, on those smokers because it's a really important cause of burden of disease. But we have to make sure that whatever we're doing here is not adversely affecting this more than 80% of the population who are not current daily smokers. And that includes children, that includes, lots of people. So when we think about e-cigarettes, we have to be balancing those things in our minds. And one of the most important, things before we even go further is to say that the vast majority of people, 2/3 to 3/4 of people who quit smoking successfully do so without any specific aids or products. And for those who need support, there are quite a lot of really evidence-based interventions that have been through medical approval. So, for example, nicotine patches, gums. And then for those who have not managed to quit by that, then there are other options. And e-cigarettes is one of the things that people consider there. So we scanned over 25,000 articles for our review and came down to 400 that were informative for it. And from that, we looked at the relationship of e-cigarettes to smoking uptake in young people. We also looked at e-cigarettes and smoking cessation. And then we looked at the direct health effects of e-cigarettes and, all the different systems in the body if you'll have it. So cancer, cardiovascular disease, respiratory health, all those things. And the ultimate, the findings of those studies were first that young people who are non-smokers who use e-cigarettes are around 3 times as likely to go on to smoke as young people who don't use e-cigarettes. And we assessed that was likely to be a causal relationship, that if you are using e-cigarettes, you become addicted to nicotine. You're also softened up to, sucking on something to that hand-mouth action that people talk about. You're also more exposed to positive messages about e-cigarettes, but also about smoking. And you're also often in a milieu, in an environment where smoking is seen as more positive. So those different factors combining together make you more likely to go on to smoke. And as I've said, it's on average threefold. We identified 25 studies worldwide, and every single one of those studies, without exception, showed that young people who use e-cigarettes are significantly more likely to go on to smoke. So that was the first main finding. The second one is that when we look at e-cigarettes and smoking cessation, there are 13 different trials, 15 meta-analyses of those 13 trials. 15 meta-analyses that include different combinations of those 13 trials. And overall, we found limited evidence that e-cigarettes are efficacious for smoking cessation. The trials that did show a positive effect were in the clinical setting, and they were for free-base nicotine, so not the nicotine salt products that we're seeing commonly used by young people now. Now, obviously, it's an evolving area. There have been quite a lot of trials registered, but not all of them have actually gone on to be published. So it's a complex area, and there are, as we said, limited evidence. But obviously, for some smokers, it can be a really good solution. So we have to balance those things. Then in terms of the direct health effects, our main comparison there was with breathing air. So we were comparing what is the effect of e-cigarettes compared to breathing air, so neither smoking nor using e-cigarettes. And what we found was overall, e-cigarettes are likely to be harmful for non-smokers and for youth. So the adverse effects we saw with e-cigarettes were, first of all, addiction, then also poisoning. There's lung injury, largely attributable to tetrahydrocannabinol and vitamin E acetate in vapes, but around 1 in 8 cases in the most large and comprehensive study were actually using standard products. We also see burns and injuries from exploding batteries, and we also see environmental harms. So things like the actual vapes themselves. We see indoor air pollution. So and they do create this complex e-waste, which is likely to also have health consequences. We saw indirect evidence of effects of nicotine on the developing brain. So if you imagine, well, our brains go on developing until we're about 25. And that's sort of, it's almost like the time when the cement is wet, that when you're laying down those neural pathways. So it's actually a time when people are more vulnerable to addiction, but not only that, those pathways being laid down means that you're kind of setting the stage for addiction later in life. So that's why tobacco companies have targeted teenagers in the past, and why the vast majority of smokers started smoking before they were 18. So that's also, so it's the age when the addiction, people are more vulnerable to addiction, but also we see effects on cognition and on memory, difficulty concentrating, those kinds of things. So putting all of those things together, the ultimate policy kind of take-home message is that it's best to avoid e-cigarettes in non-smokers, particularly young people, and any use, if use is considered appropriate, should be targeted to smokers who are looking to quit. And so, that's the kind of broad message of it.
Thank you. I know it can be hard, certainly for those of us who aren't scientists with your background in public health and epidemiology sciences, to assess the robustness of studies. So what sort of criteria did you use to find out which studies were stronger, what to include, what perhaps to give less weight to?
So we conducted this systematic review, or in fact it was a series of systematic reviews according to the best practice criteria we have now. So we wrote protocols about how we were going to do things in advance, and we had them published before we started extracting data from each study. We had the data extracted independently by 2 different people, and we also had very specific criteria where we looked at the strength of the evidence, and particularly what type of study had been looked at and how reliable the evidence was likely to be. So it took us 3 years altogether to do all of the work. It's a 361-page report is the main report, so there's a lot of detail in it. So what we were looking for was studies where we could really know the relationship of e-cigarette use to the outcome that we were looking at robustly. So, for example, when we were looking at e-cigarettes and smoking uptake, the most appropriate studies to look at there are what we would call longitudinal or cohort studies, and that's where you start at the beginning, no one's a smoker, and you work out people's exposure, and then you follow people forward to look at the outcome. In those circumstances, you can then say these individuals who used the e-cigarettes were more likely to go on to smoke, or it might have been less likely, but in this case it was more likely. And we can also look at being able to adjust for factors which might be different between those groups, like age, socioeconomic status, education, risk-taking behaviour, those kinds of things. We downgraded or didn't include evidence which we didn't consider to be informative. So, for example, we didn't look much at studies relating to what we would call biomarkers. So there are some factors, some biomarkers, or different components that might have been associated with cancer, but the problem is we can't measure a whole universe of biomarkers because some might be positive and some might be negative. So we would only look at studies which were the relationship of e-cigarette use to cancer outcomes. And one of the other things we looked at very closely was being able to distinguish the effect of e-cigarettes and separate it out from the effects of smoking. And that can actually be very difficult. So in one of the main studies of respiratory outcomes, 99.4% of the e-cigarette users had also smoked. And smoking is an incredibly strong risk factor for respiratory disease. So we found that study, we really couldn't distinguish appropriately the effects of e-cigarettes from the effects of smoking. So one of the major findings of our review is actually that there's a huge amount of uncertainty about what e-cigarettes do to really important clinical outcomes, and outcomes that are important to the community, like cancer, like cardiovascular disease, like lung health, asthma, chronic pulmonary disease. And so we don't have good evidence about those. Now that doesn't mean it's safe. I think we should be really clear. I mean, you don't walk across the road without looking. Uncertainty can actually be a dangerous situation. And one of the things that Australia and many other countries are following is a precautionary approach, which is what we apply in public health when we have an exposure where we don't know what it does. I think in the case of e-cigarettes, we do have enough information about non-smokers and particularly young people because this product causes addiction. And that's very common, and it also increases smoking uptake. But even purely nicotine addiction alone is an adverse outcome. We tend to trivialise addiction. We say, I'm addicted to chocolate, or I'm addicted to, this particular television streaming service or whatever. But actually, addiction means that you only feel normal when you have the product, and then you go into withdrawal and you start to feel craving, irritability, you're seeking the agent itself, and then you're often feeling anxious, and then you would have another hit of whatever it is. And if you can imagine, for people who are using e-cigarettes and nicotine, it's metabolized quite fast. So you're going through that cycle multiple times a day, that cycle of withdrawal and craving. And so that's what we see actually often with children or adolescents at school, having difficulty sitting through a class, difficulty concentrating, needing to go to the toilets in breaks, having difficulty sitting through a meal with family, having difficulty sleeping through the night, having the vape under the pillow. Those kinds of things are just examples of that nicotine, that addiction itself is a harm. And when I speak to young people about what they want from their future, the main thing they say is, I want an independent future that I determine. I want to live my own life. I want, a bright future that I choose. And addiction is dependence. It is actually being dependent on something else. And in many ways, it's the opposite of what a lot of young people want. So I think that's a very important thing to bear in mind. So I think in terms, coming back to your question about what we're looking at, the quality of the evidence, we have quite a lot of evidence on those immediate effects that we can see in the few years after, around using e-cigarettes. We don't have a lot of evidence about long-term harms, and it's actually really important to acknowledge that we have uncertainty about those, and to acknowledge that in those circumstances, uncertainty is not a benign situation. It's something where we need to think, right, we've got to do something to reduce exposure. You can imagine, 20 years' time, we could have, I'm not saying it's certain, but we could have an epidemic of lung disease in people who have used e-cigarettes long term, and we need to think about that. People who are smoking run an extraordinarily high level of risk, and so if those people have tried everything bearing in mind the majority will quit unaided. But if those people have tried everything to quit, then e-cigarettes can be helpful for them. And so what our review shows is that smokers who quit by switching to e-cigarettes completely and promptly may well benefit, bearing in mind the lack of evidence about long-term effects.
We always say in Scotland it's important to be evidence-based, but people have slightly different perspectives on evidence and what is good evidence for action. What did you find in doing the systematic evidence review?
Well, we looked at over 25,000 articles and screened them to get down to sort of 400 articles that we could look at. And the bottom line is that there are things that we really can conclude from the evidence, and they're really clear, that there's no dispute about them. The first is that nicotine e-cigarettes are addictive. They cause addiction, and they particularly cause addiction in young people. And addiction is a harm in itself. It's a serious problem for the person affected, and it's not something we want to see across communities. With the decrease in smoking across the community and our young people leading the way, we had the potential for generations that were going to be free from that kind of addiction. And what we're now seeing is this upswing in overall nicotine and tobacco product use and an upswing in addiction. We also know that with that increasing vaping, that actually a significant proportion, the majority of people, certainly in the studies in Great Britain, the majority of the users actually report moderate or very strong urges to vape, suggesting dependence. So that particular piece of evidence about addiction, that is clear. We also know that young people who use e-cigarettes are more likely to go on to smoke, and that's not in dispute. One of the questions is are we absolutely certain that that's a causal relationship? Our review of the evidence concluded that there was sufficient evidence that was likely to be causal. So we have enough evidence to say that this is not a beneficial thing for young people. It's much better that they're breathing air rather than being exposed to these products. Then when we look at smokers looking to quit, we know that the majority of smokers who quit successfully do it by going cold turkey. They quit without assistance. And for people who need assistance, there are registered products. And for some people, e-cigarettes can be very helpful. So that's really the group to target it. So if you take that all together, we don't need to have conversations about how strong or weak different bits of the evidence base are. We have enough evidence that says we should really be targeting these products, if they're being used, to people who are looking to quit smoking, who are fully informed of the risks and have actually tried the other products first. That's not a difficult equation to do. But what we are finding is that the tobacco companies and the e-cigarette companies are kind of absolutely, totally experienced in exploiting any sort of information. So they are bringing these products into our communities. It's kind of like a Trojan horse, bringing into our communities saying, here's the promise of smoking cessation for your people who are having difficulty quitting. But actually, when you get the horse in and open it up, the products are largely being targeted at young people, aggressively targeted at young people. They're colourful, highly flavoured. They're not smoking cessation devices largely. They've got cartoon characters all over them. And so the community didn't sign up for that. The community absolutely signed up for wanting to support people to quit. The community's had enough of tobacco, rightly so, but the community is also not interested in this kind of collateral damage of youth being addicted to nicotine in another form. So we have to think about, as a community, what are the kind of regulations, what are the steps that we can take to make sure that we're getting that balance right? The other thing industry really exploits is any sort of uncertainty and they actually generate uncertainty. So what we've also seen is the industry supports researchers, or they support front groups, and we know from the most recent studies that studies where researchers or the research itself is funded by industry, tobacco or e-cigarettes, they're 7 times as likely to find positive results than studies that are not funded by industry. We're also seeing that studies coming out of England are around twice as likely to come out with positive findings. So I think there's also stuff about the nature of research that people are doing and also the kind of culture at the time. So I think it's really, really important that we understand and are very clear that all possible competing interests are declared, but also that when we're looking at the evidence, we take into account whether or not it's been funded or by industry or whether there's any chance of bias. And we focus on how much evidence have we got that is likely to be independent, and how much can we rely on. So I think one of the things about public health is you have to take some sort of action. You can't sit around going, well, we're not going to do anything until we've got lots of evidence, because often not doing anything is an act in itself. And that's where the precautionary principle comes in. The precautionary principle is not about public health waiting and reacting when things go wrong. It's about actively seeking to manage risk. And if there is plausible evidence of serious harms, particularly those affecting future generations, then the precautionary principle says you should avoid exposure to that agent. So we already have enough evidence that this causes addiction in young people, and that it is being aggressively targeted to young people. So we have enough evidence there to say we should have measures to avoid use in young people. The other thing I think that's really important to recognise is that the young people are the victims in this. This is not something that young people thought up as, a cultural thing. It's not like amazing dancing or incredible, music, all the things that young people are great at. It's actually something that industry has developed, and it sees young people, their lungs, their hearts, their minds as their market. And they're not interested, in terms of what we see as, if it was being totally for smoking cessation, it would be a completely different marketing kind of aim, or it would be an approach. It'd be completely different. These would be registered products. They'd be designed specifically for people to quit smoking. But instead what we're seeing is this incredible rainbow variety of products and promotion to children. So the children and the young people are the victims here. And we have to stop treating them like, that they're the criminals in a way. We need to make sure that we actually reduce the supply to those and availability, that we reduce the appeal, that we stop the advertising. And one of the key factors that appeals to children and young people when you ask them about the products is flavours. There's over 17,000 flavours available for e-cigarettes. And what's interesting about those flavours is that the people who manufacture the flavours have very publicly said, we have tested the safety of these flavours for them being eaten. We have not tested them for being heated to a high temperature and inhaled in combination with a lot of other chemicals. So flavours add risk because they're another chemical component added to that emission that is inhaled. And they also are one of the things that is most appealing to children and young people. And they are not essential for quitting smoking. So if you're thinking about weighing up the risks and benefits, really for smokers, the idea is that, once they've tried the other means, they may need that delivery of nicotine that is given via an e-cigarette. It is not essential that it is bubblegum flavoured or strawberry flavoured, and those things are really hazardous to children and young people. If you think about it this way, for adults sometimes it's quite inconvenient that there's a child-proof cap on a bottle. But we cope with that because we know it's important for kids. So having restrictions on flavours is a very important means for reducing appeal of these products for children and young people.
Thank you. And just a little point of clarification and explanation for me on the science. Earlier, you were talking about the difference between cohort and ecological evidence. Could you just briefly explain that to me?
Okay. So as an epidemiologist, when I'm thinking about the kind of evidence or questions that need answering, I'm then thinking about what study design, what type of evidence is most informative to ask that question, or to answer that question, sorry. So if I'm thinking about what is the therapeutic effect of a particular medication, I'll usually be thinking, well, you need a randomised trial for that. You need to randomise people to get the drug and to get a placebo, and you need to compare those two. If I'm thinking about a sort of public health exposure that affects an individual, I'm usually going to be thinking about what's called an observational study. And one of the major types there is called a cohort study. And that's where at the beginning you start with people who don't have the disease or the outcome. You check what they're exposed to and you follow them forward over time and look at the outcome. So for example, when we were looking at the relationship of hormonal therapy for the menopause and breast cancer, we start with people without breast cancer, we look at what their exposure to hormonal therapy is, we follow them forward and we compare the exposure in the people who do and do not get breast cancer. And we also adjust for the different potential other explanations for differences in breast cancer risk. An ecological study is where you're actually looking at trends in a large population, and in that case we might say, well, HRT use or hormonal therapy use went down and breast cancer went down or up, and we'd compare those two. Now, if we're looking specifically at the causal relationship of the exposure to the outcome, we need to be using those observational studies, the cohort studies, because when we look at the ecological studies, there are lots of other things that could be happening at the same time to explain trends in the outcome. So when we're looking at the use of e-cigarettes and smoking uptake, we use studies where we start with young people who are non-smokers, we look at their e-cigarette exposure, and we follow them forward over time to see, well, what are the rates of taking up smoking in the people who use the e-cigarettes and who didn't. If we're talking about ecological data, we're looking at trends in e-cigarette use and trends in smoking. And that's useful when we're looking at, for example, monitoring how well we're doing in terms of youth smoking. But we know that there are multiple factors that influence youth smoking. There's the whole comprehensive approach that's part of the Framework Convention on Tobacco Control. There's price, there's advertising, there's smoke-free spaces, there's education programs, mass media, there's assisted quitting. All of those different forces are acting on youth smoking at the same time that e-cigarette use is changing. So distinguishing and distilling out that it is specifically e-cigarettes that have influenced that youth smoking is highly problematic. For example, we looking in New Zealand, they are announcing these huge measures to reduce the number of outlets selling tobacco by 90%. Right, so down to 10% of what it was originally. They're also having these bold measures, increasing price, lots of education. They're going to de-nicotinize cigarettes, and at the same time, e-cigarette use is going up. And we're actually also seeing positive signs in terms of youth smoking. It's very difficult to really firmly say that how e-cigarettes have, specifically affected those trends outside of the cohort study, because there's so many other things going on. And what we also see is there are trends in youth smoking, and we know that e-cigarettes increase the risk that someone goes on to smoke. So what you may see in that situation is a slowing in the downward trend. And we're worried because in Australia what we're actually seeing is early warning signs of increased smoking in those younger cohorts who are the ones who've really had a lot of exposure to e-cigarettes.
It's interesting because the very early days of tobacco, I think they followed a cohort of doctors through, and at population level they were thinking tar on the roads was causing a massive increase in lung cancer that they couldn't explain. And because they did that study, because they were able to look at the different factors, tobacco was spotlighted as the cause of lung cancer. So.
Exactly. So the ecological data identified the problem. The ecological data said, we are seeing increasing lung cancer. We don't know what's going on. And then the ecological data said, oh, well, there's actually tarring of the roads going on at the same time. And it's only by looking at those individual risk factors that you can then say, well, is it tarring of the roads? Or could it be these other things that people are exposed to? And I had a conversation with Sir Richard Dole quite a long time ago, and he said that as soon as he did the first cross-tabulation of the relationship of smoking to lung cancer, he quit smoking because it was incredibly common then, even among doctors. So I think that it's a really good example of the difference between an observational study and an ecological study. Now, this is not to say that any one type of data or type of study is good or bad, but much more a kind of horses for courses argument, that they are suited to different questions, and we have to be really, really careful that we use the right data for the right purpose. For example, it is quite difficult to use non-randomized data when you're looking at the specific intended therapeutic effect of a product. You don't get the right answer a lot of the time. On the other hand, you want to make sure that you can use that observational data, particularly for unexpected adverse events. So we learn a lot from each one of them. It's not about some sort of arms race, and the other thing that I think is really important in epidemiology is you're often looking for kind of the orchestra being in tune. That the randomized data line up with the observational data that line up with the ecological data. So, for example, with hormonal therapy for the menopause and breast cancer, we had a really great amount of alignment in the end between the different data sources when we understood the data limitations. So it's just a very important thing to I think, in a sense, have a really good multidisciplinary team that looks at the problem. So really recognising the different types of expertise and what they bring to bear. So, for example, we know people who are really good individual clinicians working with people who need to support to quit smoking, especially people who are working with people with mental health problems, people with substance abuse. Those people understand the challenges that their patients face, and they understand the place of things like e-cigarettes to help them. And they also can appreciate that you wouldn't necessarily want to make something that's available to your individual patient available for everyone in the community, because you wouldn't necessarily, you can see that there are risks and benefits there. So it's really important to be able to work together and say, we want to make sure that there's access to really good support for people who are really suffering and whose life expectancy is really profoundly affected by smoking, at the same time as avoiding generating new problems and problems for the new generations.
Thank you. And I wonder if you could explain something to me, because I'm puzzled about different forms of nicotine. I don't know quite what that means and what they do. Could you enlighten me a bit on that?
So there's two main types of nicotine that are used in electronic cigarettes. The first is this sort of original kind, which is called free-base nicotine, and that's the kind that's used that people kind of refill their devices with. It's used in the earlier generation cigalikes, but also in those big kind of tank devices and the vape pens. That tends to be free-base nicotine. Free-base nicotine tends to cause a bit of throat irritation, and it's often used in devices with variable power, so you can increase the power to increase the delivered dose of nicotine. Nicotine salts were invented as part of the dual pod system, and that actually leads to the nicotine being much less irritating on the throat, and it also means you could get quite higher concentrations with less throat irritation. And that's the type of nicotine that's in the disposable products and also in a lot of the pod products. And that's been behind, for example, the big increases that we've seen in young people in the US, in Canada, but also here in Scotland and in other parts of the UK and in Australia.
That's really interesting, because I think we've had that argument over many years about menthol, because it makes the smoke less irritating and therefore makes it easier to smoke and get addicted. And it sounds like nicotine salts are doing something a bit similar.
That's right. And so I think one of the issues we have with e-cigarettes is that we are seeing addiction in really young kids, because it's very easy to pick up this product. It's grape flavoured or bubblegum flavoured. All you have to do is suck on it, and it's not particularly irritating to your throat. So we're actually seeing kids as young as 8 addicted to these products, and huge problems for those families who might have had the products lying around with with their own good intentions of quitting smoking, and then finding they've got a very addicted young child. It's much harder for an 8-year-old to get addicted to cigarettes, because they've actually got to, have a cigarette, have the hand-eye coordination to light it, and they can't just keep on sucking on it all day, which is what you can do with a vape. So there are specific, what we call abuse liability problems with e-cigarettes with respect to childhood nicotine addiction and young adult.
Okay, so in Scotland we have a real concern for people living in difficult circumstances with low income and high rates of smoking. And I know you work closely with First Nation communities in Australia. how are they responding to this new product, e-cigarettes?
So we have targeted programs led by Aboriginal and Torres Strait Islander people to deal with tobacco. And because of colonisation, ongoing racism, tobacco is a big issue for communities. In the past, Aboriginal people were actually excluded from the cash economy and were paid in rations, including tobacco. So if you were using your wages, you were smoking. Combining that with ongoing structural disadvantage, there's been a lot of issues with smoking. Having said that, there's been incredible success in these self-determined programs and population level programs. We're now at the point where the majority of Aboriginal people don't smoke, and the youth are really leading the way there. And we know from Aboriginal and Torres Strait Islander, other Indigenous leadership, they are very concerned about electronic cigarettes. They don't want to see one addiction disappear to be replaced with another addiction, particularly for young people. So they're really keen to see nicotine-free generations, and they're also really keen to see those culturally safe programs implemented by communities and things that actually improve outcomes for Aboriginal people. So there hasn't, and they are the Aboriginal people that I've been talking to, and the Tackling Indigenous Smoking program are supportive of the prescription-only model in Australia and avoiding widespread population use of electronic cigarettes.
Thank you very much. So you're really talking about targeting where it can do good and avoiding wider harm. And that's one of the things that came out from your review for me. Any sort of take-home messages from the work you've done that we might find useful in our work in Scotland?
Well, I think that the message that comes out from our evidence is really similar to the community. It echoes and accords with the community concern that we've seen. So really what community is saying is they don't want to see increased nicotine addiction in young people, and including children and adults. And our data really shows that e-cigarette use is harmful and should be avoided in non-smokers, particularly young people. So that's really consistent. What we also see is that for some people who are smokers, who are having difficulty quitting, e-cigarettes can be incredibly helpful. And so that's about making sure that use is targeted to those people. It's a pretty simple message, but we are up against commercial forces, and these are really about the commercial determinants of health. The commercial forces would like really widespread, highly profitable products across the board. And so it's really about making sure that public health comes first, and that people's safety comes first, and that future generations come first, and that we get that balance right.
Professor Banks, it has been an education and a pleasure having you visit to Scotland, and thank you so much for sharing the research journey you've been on and the experience from Australia.
It's been a complete pleasure, Sheila, and I've learned a lot too, so thank you very much for having me.
You're very welcome. Anytime.